our speaker, Dr. Isaac Eliaz, and he has brought books. They're free. So I'd like to say a little bit about Dr. Eliaz. He's an integrative physician, a licensed acupuncturist, a researcher, educator. He does integrative cancer treatment in mind-body medicine and detoxification. There you go. Detoxification. He formulates innovative preparations that are extensively researched by leading institutions around the world. And I actually learned this evening he spoke here about 18 years ago. This is kind of what's here. But the most important thing to say about Dr. Eliaz is that he is a healer. So please join me in welcoming Dr. Eliaz.
Our biggest challenge is that we don't have a mic, because although I am Israeli, I speak very softly, which is a true aberration, so we'll see how we do. So tonight, this is just a topic. I want to share with you a little bit about my philosophy of medicine. It's really interesting to be back here. I was here sometime in the late 90s, and I remember a very interesting discussion about CoQ10 and membranes. The internet wasn't an issue. EMF wasn't such a big issue. There was just a study unrelated last week that didn't make it big enough in the media. That I think people over 25, they even didn't look at children who use cell phones frequently, has triple. They said there was some increase, and when you read triple of the incidence of gliomas, these are the deadliest tumors, okay? So there's no doubt about the damage. I'm very lucky. I live in an area on 5 acres, and when we turn the Wi-Fi, there is no Wi-Fi. And sometimes there are guests, and we see very clear when we don't have to tell them. If we turn it off for the night or we don't turn it off, it's a very different quality of sleep. So even just here, I know you turn it on, and we don't have a smart meter, so again. But let's talk a little bit about what the topic of today. So I'm going to talk a little bit more about then modified it with pectin, although it's a very important topic that has been getting more and more validation. So I want to talk about what is integrative medicine. Now I heard here different questions from different people, and as research continues to come out, you may find out that you get less and less of a clarity what's good for you and what's not good for you. And the reason is that Western medicine is, from a Tibetan perspective, is having fruits and leaves with no branches, no main trunk, and definitely no roots. And to really understand what to do, we have to have roots. Like the grounding is an example, And you said if the soils are from rubber, there is no one tree anymore, we are cut. So also philosophically, when we look at medicine, we want to see what is this term integrative medicine. It's a very common term, but actually it's not as easily understood. So the first principle in integrative medicine is that it's patient-driven medicine. And this by itself we can spend hours. If you come to our clinic, to Amitabha Medical Clinic, there are no white coats, there are no diplomas, no one sits behind a desk, and it's Isaac, and the patient has a nicer and bigger chair than I have. And that's part of the principle of empowering the patient. And this by itself is a key issue. There are often patients, I do a lot of work with cancer, there are often patients where chemotherapy is very important for them and they just don't want to really do it as a resistance. And often they will come to the clinic and they will walk out and luckily decide they're going to do chemotherapy. Not because I convinced them, but just because they had enough space that they felt that they are not pushed and they could see what's right for them. And sometimes, of course, going the other way around and realizing it's not right for them to do. So this group is really all about patient-driven medicine. That's what you guys are doing. You're trying to educate each other, and you are trying, I would say hopefully, but I would say hopelessly in the last few weeks to educate the doctors. I just came from Society of Integrative Oncology where I presented 3 poster sessions. One is on honochiol, intravenous honochiol, which we are the only people in the world who do it with dramatic results. And I had to catch up on sleep, so I admit most of the time I sat in the room and slept because I was going to Israel. But there was a main session, the person who was the head of MD Anderson before, 18,000 people, biggest cancer hospital, and another 2 people, and they were talking about integrative medicine. And it was really appalling. If I would follow their advice and you came to my clinic, most of the patients you will see doing well would be dead. So, we have to vacillate between what this integration is going to entail from a point of view of politics and money and people who just don't have time to think out of the box or not allowed to think out of the box, and between really what is integrative medicine. So the second principle, which is very important, is that integrative medicine requires no bias. That's why there is no such a thing like alternative medicine. It's really about integration. And it's a very difficult process to have preconceived ideas or judgment. The more we know, the more educated we are, the more we have ideas, the more we have judgment. It's a real art to learn and to unlearn in the same time. And that's really one of the most fascinating journeys in life, more fascinating than any molecule I'm going to talk about today. And integrative medicine is individualized. For example, now in oncology, they were talking a lot about it in the conference. They are now trying to individualize care based on genomic expression, epigenetics, based on chemosensitivity. And it's interesting, we've been doing it in the clinic for 20 years. And as they say, first they ridicule you, then they fight you, and then they say that it's self-evident. So in my personal journey, I'm at the self-evident stage right. That's where you see who I do research with, but it wasn't this way 5 or 10 years ago. So for medicine to be individualized, we have to be open-minded. The only protocol that I have is that I don't have a protocol. I truly don't have a protocol. So it requires a lot out of me, a lot of time, a lot of energy. And that's why somebody make a comment. It's not about, I think you made a comment about don't believe, see what works for you, n equals 1. So one part is to individualize care based on the disease. And although progressive oncologists are really excited about it, it's really not complicated. You send to a lab test, you get the genes, and you follow the recipe. What's really hard is to individualize based on the person. And that's when you have to shift from knowledge, from information, into wisdom. That's really where healing comes. That's really the journey of life as an expansion. So the image is the image of the circle, because when you look at the circle, there are no corners, there is no judgment. The circle has no bias. And within this circle, we have different methods. So for example, I look at my small journey. So I actually did yoga in my teens. Maybe I'll tell a little bit about me. I'm a native of Israel. I started my journey of healing at the age 15 when I lived in Korea with my father and my mother, who was an engineer. And I learned taekwondo and martial arts and yoga. Came back to Israel. I was a yoga teacher even during my army service. And when I went to medical school, I already knew that I just have to survive all these years and do what I believe in. So I learned yoga. I became a yoga teacher. I learned shiatsu, and I learned acupuncture for 3 years. And when I graduated from medical school in Tel Aviv Medical School, I taught acupuncture with the Hebrew University of Jerusalem. Then I came here and I studied Chinese medicine. I did a Master of Science, became a licensed acupuncturist, and was planning to go back to Israel 2 or 3 years later. But we met our Tibetan Buddhist teacher, Chagdud Rinpoche, and the Tibetan Buddhist path became the centerpiece of my life, of our life. And I also learned classical homeopathy for a few years and nutrition. So I took this thing about taking one topic for a few years, one topic for a few years, one topic. And finally, at the age 40, I went and did a residency so I can get my medical license in this country. So I kind of went through this process, of learning. Because usually if you are just here, then everything here out of your scope can be very scary, very fearful, It's fear-based when you don't know something. You're either really courageous enough to be there, or you just fold back and retreat, which is a normal process that people go through. But the real journey is the letting go. Is the letting go and just letting go of the concept. You know, I'm sitting here in the standing in the Silicon Valley, the center of too much thinking. Now, and you can see it right here. I mean, you go to Tel Aviv where they have like a peace gathering, and you can feel the IQ, like you get electrified from it. So much thinking. So it's good thinking. You can do good thing with thinking. You can do bad thing with thinking. But one thought will always lead to another thought. So the idea is that when we move away from the conceptual thinking, that we touch our intuition, we touch our insight. And that's really where healing is. You will see at the end of the lecture, I will present my cutting edge new research. It is not related to any product. It relates to, it's really a whole new field in medicine that I'm creating. And it's not an exaggeration. So as part of it, I'm having many people with chronic Lyme's come to me. And I had a patient, very complicated, from out of the country who came. First time he came, he left after 2 days. He was allergic to everything. The concept, you know, even before. And then this time he came and I got it, I kept him, you know. Eventually he didn't do the second treatment, but towards the end he told me, Isaac, he said, I'm so many years, really he's treated by so many people, he said, but something different happened here. It's the first time in so many years that I still have my symptoms, but I'm feeling better actually. He said, what happened? And I told him, I'll tell you what happened. You were treated by doctors, and now you were treated by a healer. It's very, very different. So the healing journey is the healing journey of the patient. And our job as doctor, if there are doctors here, is not, first of all, not to stand in the way through the concept of skepticism. There's a big difference between discriminative wisdom that comes from knowing, and between skepticism. In Western culture and Western medicine, we are learned to be skeptical. The double-blind studies is based on skepticism, the doubting. It's actually a kind of adding a little bit to some radical views, which usually I don't have. It's a built-in system that doctors don't know about it. I went through medical school. The doctors don't know, the professors don't know that it's a whole system where you can give a drug only by randomized controlled trials. Okay? And when you can do it only by randomized controlled trials, you take away the individualized care, the N equals 1, and you take away the simple remedies that can help people, because who can afford a randomized clinical trial? I'll tell you a story about it. I had a very complicated and non-compliant patient that a friend asked me to see for free with melanoma. Didn't do anything, melanoma went deeper. Didn't do anything, came up with stage 4 melanoma. Was put on a drug called BRAF inhibitor. Everybody in the study died. There were 2 survivors, and about 4 months ago the other person died, and he's doing so well. Okay? So it's one person, it's not enough, but imagine if there were 3 like him out of 24, the drug may have been approved. But he didn't tell the doctor that he was taking 17 pills a day of my honokiol and 20 grams a day of my modified citrus pectin, which both have very synergistic effect against melanoma, and honokiol is specifically a BRAF inhibitor. So much, you know, and that's a problem with when we try to isolate one factor out of life, which is so complex. Like you asked about vitamin K, different vitamin. You know, vitamin K can be used for bone issues. It can be used for hyperviscosity, and I have extensive experience using it as a cancer agent together with vitamin C from K3, from a totally different mechanism. So moving on, we're
trying to get you a microphone.
Oh, thank you. Perfect. See, look at this. I'm just talking about time now. Perfect timing. Perfect timing. Oh my gosh.
So that you can put in your pocket or on your belt or whatever you
Oh,
like.
thank you so much.
This is not going to sound as good as it should.
No, anything is good.
Okay, so now,
Oh, I better.
so just put it. Oh,
Okay.
hang on a second. Well, you have a microphone already. Let's try that.
Wow. Okay, that's better, right? You can hear? Yeah, a little bit louder. Okay. So in Chinese medicine, we look at diseases as journeys in time. So if
Maybe.
well, you know, it's too much to ask for a mic and to see the pictures, especially in the Silicon Valley, right? I mean,
It'll happen sooner or later.
There you go.
okay.
Well, turn it down just a little bit. That cures everything. XL1.
Okay. So this is a very common highway, right? I mean, it actually almost looks like the 380 and 280 from the airport. I wonder if it is. But there are hundreds of highways like this, and this will end up resulting in very common diseases. This is a very unusual highway that will lead to a very unusual disease. So each of us have our own highways, and diseases in this, from this point of view, are just consequences of our journey. So it's very important, for example, in cancer, because if somebody is here in an unusual cancer and I can take their pulses or see their behavioral pattern, I know that when they get to here, they will have cancer. Certain rare cancer, let's say multiple myeloma, okay, or lymphoma. So I know if I can interrupt the highway and move them to another highway, I prevented a disease. And that's really preventative medicine. Preventative medicine is really very rare in Western medicine. It's more about early diagnosis. Although now with gene expression, it is changing. There are definitely changes. So in oncology, which is a big thing of what I do, we look at this relationship. When we do conventional therapies, we got to stop the disease at any price, even if we damage the health. In holistic approach, a lot of what many of you are speaking here, right? Some of you asked questions about DHEA for health, and some asked about using something to remove heavy metals, right? You did exactly, you actually wanted to promote your health and to remove your disease. So this is a very dynamic approach. So on stage A, it's when we don't see the disease, but it's cooking. And again, that's where epigenetics and that's where it's starting to come into Western medicine. And then that's really the very dynamic model, where the same compound can have different effects at different times. So for example, when I treat people, and if we have time, I may touch a little bit about my approach to cancer treatments, I will give different let's say that you have a 21-day chemo cycle. I will give you different supplements on day 1 to 3, day 4 to 6. It will change. It's very dynamic as we move through this. So some general approaches for cancer that I will talk specifically more about modified cytospectin today is prevention of metastasis and angiogenesis, new blood vessel growth, which modified cytospectin does, immune enhancement, hormonal and metabolic modulation, very, very important, and that's the comment about the DHEA. What is a downstream? What will happen, you know? Direct cytotoxicity, antioxidant, anti-inflammatory, and antimicrobial approaches, detoxification, circulation hyperviscosity, and redifferentiation. These are just some categories. There can be, of course, other categories. So, from our perspective, I took some slides from a lecture I gave to our local oncology group in Sonoma. We now have a good relationship where they actually send me patients. Of course, the patient was stage 4 and there's nothing more to do, but still there's an exchange now, which is a nice thing. There's no such a thing like alternative medicine, only integrative medicine. And integrative medicine is a powerful tool that can really change patients' outcome, both quality of life and survival. And maybe a comment, I spent a long dinner with the head of the integrative oncology program in MD Anderson, who is a therapist, and he asked me if I can send my best case report about people that got cured. Yeah, and I have a few of these, but it's not the point. Whatever I tell you, the point is that every single patient, almost every single patient, lives longer and have a better quality of life. Yeah, here and there we'll have miracles and people will get cured, but the idea is that people can do better in general when you integrate things and make them more effective. So the patient, that's a little bit about our patient population. Again, it's from an oncology lecture. So the integrative oncology has a vital role in early diagnosed patients all the way to the late stage. I try to tell them, look, Even when you have a breast cancer patient, when you have a 70% chance for a cure, you feel like you're in good shape. What if I can take it up to 85 or 90? But we're not there yet from a referral point of view. So our unique approach is that we integrate diverse modalities for better care, less side effects, and improved life quality and survival. And we are utilizing mind-body medicine as a powerful tool for survival, healing, and personal growth. Again, this is not the topic of the lecture, and it would be nice to spend more time on this. This is a little bit of a buzzword, mind-body medicine. I'm talking from my own experience, since starting to meditate when I was 15, 1974, and since 1990, spending 2 months a year on retreat and taking 2 years off to meditate, and since 2004, meditating half a day, working half a day. So I've sat on the cushion, and you see what it does to patients. You can take a patient over a weekend, and their cancer markers will change. And I do a lot of these retreats in Israel, and I'm talking now to a big medical institute, and we may do a clinical trial around these retreats to check, in addition to questionnaire, to actually check cancer markers, inflammatory markers, and immune markers. So, our research partners, as I mentioned, we are actively researching with Harvard and Mass General, Johns Hopkins, Columbia University, which we published 2 papers, Boston University with an NIH grant, MD Anderson Cancer Research Lab, Mayo Clinic, University of California, Davis, University of Kansas, University of Tel Aviv, a few hospitals, Technion, Meir Medical, Nanjing, China, USDA, a very big congestive heart failure institute in the Netherlands, University of Hull in UK, and Tufts University. So my work at Amitabha Clinic, my compound, is researched now by all of these institutes. That's what I mean. Now they say it's self-evident, but it didn't. This list was much smaller 3-4 years ago. So it's nice, but it didn't. It's like what you call a 20 years overnight success. Oops. So let's talk about galectin-3 research. So it's really about the role of bioactive biomarker galectin-3 in cancer and chronic disease progression. So what is galectin-3? How many people here heard about galectin-3? Oh wow, that's quite a few. So galectin-3 is a multi-locational, multifunctional signaling protein, which means it's present in the nucleus of the cell, in the cytoplasm, in the mitochondria, in the cell surface, in the extracellular fluid, and in the circulation. It has different roles in every area, which some of them are not known yet. And it plays an important role in regulatory roles in cancer, in inflammation, in fibrosis, and in immunological response. I was instructed to point and to clear it, so I hope that's why I'm doing this. I'm following instructions. So, it's a it's a biologically active serum marker for high risk of mortality. Again, it's a culprit biomarker. It's not only a marker, it's actually involved in multiple diseases and in death, because it promotes metastasis, inflammation, and fibrosis, and it predicts outcome. So in cancer, galectin-3 plays a role in cell adhesion. Cancer cells need to touch each other to create an environment where they can survive and take nourishment from the connective tissue. Aggregation of cancer cells, tumor growth, metastasis, angiogenesis, inhibition of apoptosis. It stops cell death, and immune evasion. And these are some very good reviews that you can look up if you want to. I can send you abstracts. We have it all organized. So these are more about, specifically now there's a lot of interest in serum galectin-3, the tumor marker, in more and more cancers. Just in the last week, there were two papers. One of the importance of galectin-3 in stomach cancer, and second, the importance of galectin-3 overexpression in increased aggressiveness of triple-negative breast cancer, when there's no good treatment out of chemo if you don't respond. And it's interesting, galectin-3 is responsible for specific organ-specific metastasis. This paper was specifically about MMP9, a molecule that breaches the vascular basement membrane and allows the cancer to get out of the blood vessels, and it was blocked by modified citrus pectin. So the thing that really made galectin-3 come to the forefront is actually cardiovascular disease. I started my journey with modified citrus pectin when I was 13 years old. Like they say in Israel, since when did you want to be a doctor? Since my mother's childhood. But actually I was 13 years old, and we took a walk to our neighbor Leo and Ruth Cohen, who were PhD in organic chemistry and the pioneers in the citrus industry. It was 1970, 71, and Ruth out of the blue turned to me and said, Isaac, one day they will find a treatment for cancer from the peel of the citrus fruit. And almost 25 years later, when the first research came out, I was here in San Francisco. For some reason, it stuck in my head. And when the first paper came, I picked the phone, I told her, Ruth, you don't remember, but I remember what you told me. And she's the one who put me in touch with the pectin scientist, and that's how I started my journey. But at that time, the focus was just on specifically on cancer. I discovered the role of modified citrus pectin for chelation, and I discovered the role of modified citrus pectin as an immune enhancer and as a galectin-3 blocker, which I'm still fighting with the US Patent Office to get this one patent. But what really brought it to the forefront is cardiovascular disease, and you will see why. So galectin-3 is a target therapy in heart failure, and that's why now there is it's got enough attention, and the NIH is sponsoring a double-blind clinical trial with my compound in Boston University. So why? So this is a PREVENT study. It's a study done on 8,000 people. This is a Birmingham offspring study. So they have blood tests from people when they are 50, and they follow them for 11 years. And here is what they see. They see that in general, if that's the baseline, people at the bottom 20% of concentration, 7.7 and 9.4, after 10, 11 years have about 5% mortality. People with 15.6, which is less than double, have almost triple the mortality. So the all-cause mortality just based on galectin-3 levels is so dramatic. And the nice thing for us is when this study, even before this study came out, the FDA just approved a blood test for galectin-3, which is inexpensive and paid by all insurance companies, even medical, even Medicare, as a cardiovascular risk, but we of course use it for other things. So that's a very large study, 8,000 people. And you can see that galectin-3 related to more diabetes, that's the average, but 2.3 to 6.1, heart attacks, 1.8% to 7.4, hypertension, and strokes, twice. So multiple diseases. This is specifically circulatory related issues. And this is, for example, you can see the relationship with inflammation, C-reactive protein, which is not as simple. But you can see the ratio is about doubling of the galectin-3 between this group and the other group. It was 15.6 and 7.7, and you can see doubling of the C-reactive protein. That's a very interesting topic that I published on. That's a very interesting study that looked at patients with congestive heart failure. And that's one of the interests of the NIH now, is to see patients with high blood pressure who have elevated galectin-3 above 17.8, can we prevent them from going into congestive heart failure? Why is this so important? Because if you have congestive heart failure with elevated galectin-3, 100% of the people are dead in 3 years. So if you look at this group, overall mortality in 1 year from people with congestive heart failure, class 2 I think it was, 1 out of 8 if you're under 17.8, and only a 50% increase, 3 times the mortality in 1 year. So you can see why it's getting attention. I mean, it's interesting how things happen. The company who developed the assay, BG Medicine, Peter Manham was the CEO and the scientist. You have to be talented, not him, the people, to run something so badly. And that's why you have to try hard. And that's why people don't know about the assay. But he was telling me when he met the head of Harvard cardiology, I think in 2011, he didn't want to hear about it. When he came to his room a year later, he asked him, "Do you have any question?" He asked him, "Can I borrow your jar of modified citrus pectin?" That's how things are changing because of all these studies. So galectin-3 is why is this happening? Because galectin-3 is a molecule that is in charge for the repair system. And when we repair through inflammation, and we repair through fibrosis. And that's over dinner, somebody was talking about inflammation. There's a big difference between acute inflammation, which is a necessary immune response that protects us, and between chronic inflammation, which will kill us. So galectin-3 promotes activation of M2-like macrophage, which in turn causes activation of myofibroblast. Galectin-3 promotes myofibroblast activation in differentiation, promotes collagen 1 synthesis, and increase in IL-6, IL-8, which are the chronic inflammatory cytokines that over time, if people don't know what is fibrosis is taking something alive and making it dead. So any part of the tissue, of the blood vessels that become fibrotic is not functioning anymore. So hepatitis will cause cirrhosis, kidney damage will cause kidney failure. Stroke can cause damage to the brain, etc., etc. So every chronic disease, the dysfunction of the organ is based on fibrosis. It's really you can see across how many diseases. Because it causes adverse remodeling. For example, in ischemic heart disease, if you had a heart attack and you didn't get oxygen for enough time, the cells move to a different metabolism, you get fibrosis, right? The cell stops contracting. So it affects heart failure, hypertension, arthritis, asthma, diabetes, cancer, every single disease. And let's skip all these papers. So in the same time, galectin-3 is a very important immune modulator. There's a very common term that I'm sure you guys spoke about, biofilms, right? I mean, you had a discussion about biofilm. The biofilm is made out of galectin-3. This is published. Because the same biofilm is a concept of escape. You can have biofilm in the gut, where bacteria can hide. You can have biofilm in the blood vessels, where viruses can happen, Lyme's disease, plaques, toxins. You can have biofilm around the cancer. This is why certain chemotherapy drugs will not work in the environment of high-level galectin-3 and high level of inflammatory and hyperviscosity agents, such as fibrinogen, such as CRP, such as LPA, plus cocktails of heavy metals, etc. So that's really a process. And I think these things are proven now. Galectin-3 clogs them, and I'm not showing too many studies because it's already too much. The membrane of most cancer cells and is involved in metastasis and endothelium recognition as well as in evading immune surveillance. And we've done a very nice study to prove it, which I will show you soon. So the nice thing is that now we can test galectin-3, and again, the trick, if any of you is testing galectin-3 and your galectin-3 comes under 17.8, you will see that it says that your galectin-3 is normal. But it's not normal. It's normal for the patient with congestive heart failure, because this is what the FDA approved it for. You saw that at 15.6, there is 3 times the mortality. And one of the fascinating things is what is the relationship between systemic levels of galectin-3 and galectin-3 at the target tissue. And I will have some answers for you, because this is really the pioneering work I'm doing right now. So if we look at this, at this level, they are considered, from my perspective, it's interesting because I'm really the first clinician who is using it, just like with the modified Pectin dose. So you get to set up the numbers, you know, and then, but you do it based on certain knowledge, such as this study, and slowly you have to disseminate the information. And when people start giving you the information, you know that you start doing a good job. And now people heard about it, it's coming back to you. So for cancer and cardiac patients, you want a much lower level. For regular population, around 14. And galectin-3 level really fluctuate all the time based on our stressors, etc. So it's good to repeat the test. And you can address it by the condition, by galectin-3 level, and by your therapeutic goals. Either by changing your diet and lifestyle, which is a lot of what you guys talk about all the time, by using modified Pectin, which is the only proven natural galectin-3 blocker. I'll show you the research. And this is a new thing I'm going to share with you today. Very, very new. So, what is the relationship between modified Pectin and galectin-3? The topic of the lecture that I'm getting to now. So this is the structure of regular pectin. Pectin is a long molecule of galacturonic acid, which is usually esterified, and it has these side chains of neutral sugars, arabinose, rhamnose, which are very mannose. They are very important for immune recognition. You know, the whole concept of oligosaccharide. So you want to modify this pectin from a very high molecular weight of 50 to 300 kilodalton with high level of esterification to an optimal biological activity, molecular weight well under 13 kilodalton, so it gets absorbed, low level of esterification, and specific structure on a three-dimensional level. So, and what modified Pectin does, as a galectin-3 blocker, it binds to galectin-3, it blocks, this is in cancer, blocks aggregation of cancer cells, block docking of cancer cells, and block interaction with the endothelium necessary for angiogenesis. So, just briefly about the research, it started, first papers were published in 1993, 95, and it was shown that when you treat with MCP, it has an anti-cancer and anti-metastatic effect. It has blocking of galectin-3 effects, synergistic effect with chemotherapy, protection against post-radiation damage. Anybody that flies a lot, for example. I do a lot of research on the danger of flying. Detoxification and immune support. So, this is a classical landmark study by Pienta that was published in JNCI, one of the best cancer journals, showing that when they took mice, they implanted androgen testosterone insensitive resistant PC3 cells in their hips. After 4 days, they gave them water, 0.1%, MCP, or 1%. And there was a dramatic decrease in the metastasis to the lungs, both on the number of animals and the number of sites. And I really like to say, and it's true, if this was a drug, it would have been a multi-billion dollar. But it's only from the peel of the citrus fruit. It's so simple. And so obviously it didn't catch the attention. So, but this was really the first time ever that any substance, pharmaceutical or natural, was shown to affect the metastatic process. It opened a whole new field in thinking. I mean, the endostatin, the different, Judah Falk and some of his substances were years after this, towards the end of the 90s. And it's another study by this group that showed that actually they took breast cancer and they showed that when MCB inhibited not only metastases, breast to lung metastasis, 0 compared to 100% in control, but it inhibited the size of the primary tumor. The primary tumor didn't grow as fast, and it was proportional to reduction of blood vessels. So, and it had a relationship with galectin-3, and that's the first time that they realized, wow, there is an effect on the primary tumor. So this is our first study, where it's an ex vivo study where we took human vascular endothelial cells layer from the umbilicus, and then we put PC3 cell lines, and there was on control, there was no killing of the cells, and then it's 0.1 and 1%. Now this is the first clinical trial. On 7 patients we did in 97 with Dr. Stram. And we actually, the majority of this is people who had localized prostate cancer that was treated. There is no more prostate. The PSA goes to 0 and it starts coming up. When PSA comes up, after you take out the prostate, it signified prostate cancer because there's no prostate anymore. And so the way to evaluate it is by seeing the changes in PSA doubling time. And the MCP significantly increased the PSA doubling time. It slowed down the growth of the prostate cancer. So this is, you can see on some in a very dramatic way, 190 to 3. So there were 5 out of 7 had a response, 4 response, 1 partial, 1 stable. Usually after a few months it will get worse. Within 6 months there will be a 25% increase. It goes faster. So then we did the phase 2 study. It was done on more than 10 patients, and that's a little bit about the politics of medicine. And this patient, it was an IRB study. Patient didn't take any supplements for 6 months, no hormonal therapy. They were followed every month with PSA before, and then for 1 year with the MCP. It was very interesting. Almost all the patients, 8 out of 10, had significant slowing down of the process. The doubling time increased. Why is this significant? There are many things that slow down prostate cancer. But very often, even the natural compounds are hormonal related. And when you change the hormonal biology of the prostate cancer, the clock starts ticking. Here, it's a binder that does not affect the hormonal system, but also enhances the immune system. And that's why every day you slow cancer with modified citrus pectin is a net gain of life. That's what's so unique about it. Now, what was very interesting is that the same study was published in the journal Prostate, a very prestigious study. But it was not published under the dietary supplement, but it was published as a statistical method to measure how fast the PSA goes up. And these 2 people had negative numbers because their tumor shrunk. But because at this point there was no knowledge that the MCP can affect the primary tumor, the paper I showed you a few minutes ago wasn't published yet, the physician assistant took this data out and published only on 10 people. There were really 9 out of 12 response. 2 of them, the cancer got better. But that's part of sometimes negative bias. He just said it's impossible, so he took out the data. Not good science. But what was interesting is that Dr. Schultz, who was the head of the paper, told me is that you see, this is a monthly 6 times. If the primary tumor continues to grow in the same pace, but there are no metastases, you'll get a straight line. So the fact that it flattens right away means you have to affect the primary tumor. So this person had a lot of benefits for 20 months. And that's a study on advanced cancer patient who took modified citrus pectin, published in 2007. And surprisingly, this patient had an improvement in their quality of life, in their inflammatory symptoms. At this time, we were not very aware about the whole galectin-3 and fibrosis and inflammation. So we had the data, it was published, but the understanding was not there. And that's another study we did on mice showing that it prevents colon to liver metastasis. And that's a study we did with Columbia University, showing that the MCP itself had direct anti-cancer apoptotic effect on multiple prostate cancer cell lines, androgen dependent and independent. So pretty significant numbers. Again, it's not the main mechanism, and we just repeated this now in Israel, where we are going to present a paper showing synergistic effect with radiation therapy. Now that's interesting. This is actually a study from Iran, from Tehran, where they got hold of my compound, I don't know how, but it's fine. And they actually already presented a number of papers. And in this study, they've shown a synergistic effect with doxorubicin, which is one of the most popular and most toxic chemotherapy drug, with a lifetime dose limitation. And you were able to lower the dose by 25% and get the same response. And they also showed, in another study, they just showed in ovarian cancer, the same group actually, showed that it's synergistic with, I'll show it in a moment, I think it's not here. It's synergistic with Taxol and Carboplat. So you can see multiple drugs. Why? Because of the biofilm concept and because of the presentation to the immune system. So MCP has an important use. Oh my gosh, I'm not very talented when it comes to the right buttons to push. Oh, am I going in the right direction? Here I am. So MCP is especially important post-radiation induced inflammation. Often, and radiation means injury. Radiation means, trauma. Radiation means surgery. The same issue when you get injury to a tissue, and the tissue it gets inflammation, and it tries to recover. So right now we have 2 clinical trials in recruitment. We have a phase 3 trial in Israel for biochemical relapse of prostate cancer. The recruitment is going a little bit slow, so we just added some more hospitals, but it's interesting because it's a single arm. We know it's working because the first 10 patients, you clearly see the effect. So now the doctors are more excited to recruit. Very good, well done study and then we have the NIH study with hypertension that I mentioned. So modified Pectin also has a very unusual immune support, which again, we were surprised. So we tested, I do a lot of work with medicinal mushrooms, and we tested multiple medicinal mushrooms and MCP, and MCP was much more effective for the immune system than any medicinal mushroom. The reason is that 10% of our modified Pectin is rhamnogalacturonan 2, which is the active immune enhancing molecule in mistletoe. And it does get absorbed through the gut. So we showed that MCP induces natural killer cell activation, activity, T cytotoxic cells, and increases B cell activation. So this is a study we did with Miami Children's Hospital, and it's an ex vivo study with the USDA for analysis. And what we showed a very significant increase in T cytotoxic cells, the ones that kill much more than the positive controls. An increase in B cell that wasn't as dramatic as a positive control, but still was significant. No, this is still 200%. And you can see how it goes in a straight line based on concentration. But most important was natural killer cell activation. So there was a dramatic activation of a natural killer cell, much more than interleukin 2, up to 1,000%, but even at very low concentrations. Look at it like a straight line curve. So it's very easy to reach this or even this level. Even 800 microgram is not a high level to reach when you take 15 grams a day. But then, of course, the big question was, it's great that you activate the cells, but how good are the cells? How good of a soldier they are? And again, so we tested the activity. Again, I'm not showing you the whole paper to save on time. And we showed a significant increase in the activity of the cells. So not only more cells are waking up, but they are more active against cancer. And that's probably one of the roles why modified Pectin has so much promise, especially as a synergistic compound with other treatments. So I know I was supposed to, now I know how you choose the titles. I had dinner. You choose the titles so they look interesting for the public. But I took it seriously. I prepared my lecture based on the title. So we talked about modified Pectin and its role in chelation and detox research. The idea came to me after the Chernobyl incidents. Some of the children in Ukraine had very high radioactive readings. And when they were given pectates, which are high molecular weight, The pectins, so it was in the food. And the pectins were absorbing the radioactive material in the food, and the children got 50-60% reduction. Interesting, the abstract disappeared from the literature a few years later. And now they came back in the 2000s when some of the institutes did research. So when I saw this, I said, and there was a mechanism, I said, well, if I modify the MCP, it has to be a systemic chelator of positively charged heavy metals. Because most of the radioactive material, except for iodine, is positively charged. Uranium, cesium, etc. So here, MCP is a very powerful binder, and it can remove different heavy metals. And its unique structure is selective binding affinity for lead, mercury, cadmium, uranium, aluminum, and arsenic, much more than regular mineral. It does not deplete the body from minerals. And the mechanism is what you call it's a mechanism of the polyuranides, of the alginates and the pectins. It's like the egg box. Or I like to, when you see for gold, and the heavy stuff comes out and it gets bound. The pectin is negatively charged, the heavy metals are positively charged. So it binds them and then it excretes them from the body. There's still more research, of course, about how exactly it's being excreted. There are a lot of still unknowns. So this is a study that we checked the short-term excretion of heavy metal. It's a study we've done with UC Davis and with a grant from the NIH. And we saw that, and so it showed the effect on day 1 and day 6. Subjects were given 15 grams of MCP a day for 5 days, and on day number 6, 20 grams. And what we saw is an increase, I'll get it at some point. What we saw is an increase in day 1 and day 6 of arsenic, cadmium, lead more on day 6 because there was mercury before, and aluminum. So really, all the positively charged heavy metals were taken out. So the question is, that's great, but what will happen on a long-term basis? And modified with pectin, at least at this point especially, it's very gentle in its works in the circulation, probably in the microcirculation as well. And then through gradient, it should slowly take down the concentration in the tissue. But as such, it's a very good thing to combine with harsher chelators if you need, such as DMSA or EDTA, because it will prevent the redistribution. So when you do detox, if you start with MCP or MCP alginates, you will not see side effects. I mean, you never say never and you never say always, but it's literally very close to it. I have never seen a side effect from MCP from chelation because it clears very gently, and only then you want to introduce alpha-lipoic acid or cilantro or any other agent that cross the blood-brain barrier. Otherwise, you get a heavy metal molecule from a fatty tissue and you redeposit it in the brain or NAC, etc. So that's the priorities. You clean the circulation and you have the alginate that catches it in the gut, and then you can use other chelating agents. That's why it's our phase 2 detoxification. So we wanted to show this. So we gave patients 15 grams a day for 4 to 10 months, and we did a DMPS challenge, IV, and 4 hours collection of urine for mercury levels. And we saw we did not change the diet of the patients. Okay, very important. And we saw a very significant decrease, 62.17, which is really what you will get if you do chelation with IV, and which ranged based on how high it was to begin with and how long the patients were taking this. So that's very interesting. Now, this patient is fascinating. 180 is extreme levels of mercury. So this actually wasn't a cancer patient. He had irritable bowel syndrome and elevated liver enzymes. And you can see how dramatic it came down to 49, and later it came down to 31. So he really got rid of 80% of the mercury. His liver enzymes went back to normal. His irritable bowel syndrome went away. Now this is in Northern California, in Sonoma. We eat a lot of fish and seafood. He kept his diet, stopped the MCP after a year, came a year later. What happened? Mercury was up over 100. We gave him again MCP, it went down. Now, interesting, this person has a family history of Alzheimer. And there's a tendency in the family to accumulate aluminum. And it's interesting how he's very easily not able to discharge the mercury that some other people are able to. So it was a great N=1 study on someone who took it, same diet, stopped it, and took it again. And we actually published this as a case report, but I'm not going to show this. So again, it was promising and very, very safe. That's a very important study that we did on children with lead toxicity. We did it in China. And unfortunately, we did it in 2007, where the tainted lead with the toys happened. And after 7 or 8 children, we got a phone calls, and there are no more children in China with lead toxicity, and they stopped the study. Now, you will be amazed what a problem lead toxicity is in this country, especially in the inner cities. See, we all worry about Prop 65, right? You know, Prop 65, you're not allowed to have more than 0.5 microgram a day of lead in a substance, which is ridiculous. You can't eat anything. Any fruit you eat, anything you eat, you will get more. But it's bound. Some of these herbs, the lead is so strongly bound, they're actually chelating agents. The problem is in places like Washington, D.C., you have 6 to 10 parts per million in water, which is 100% absorption, which affects child development. And you know there is unleaded gas now, right? You know what gas has lead? You all should know because you're getting it every day from SFO. Airplanes use leaded gasoline. So when they take off here and they land, they are spraying you, all of you guys, with lead. There is no way that you don't have high lead. Impossible. And of course, in third world countries, like in Nepal, for example, you just take a deep breath and you get lead. It's incredible how polluted it is. So in China, with the one-child policies, there are counties where 60% of children have toxic levels of lead. And I'm working with the CDC, with an African-American doctor who is passionate because it affects their population much more. And we have a 501c3 non-profit for children, for homeless children, called Our Kids' Sake, that now we expanded into Amitabha Wellness Foundation, where I also, when I teach about meditation and healing, I do it for free anywhere in the world. So it's an offering, and also we sponsor research and we sponsor patients who don't have money for treatments. But a lot of the focus is with children, and what we started doing now with my daughter started this project, my younger daughter, our younger daughter, is that we are trying to put high quality filters in the homeless shelters. Because one filter, a few $100s, can give good quality water for cooking and drinking for hundreds of people and change their health. So here is what we saw in this study. It was very dramatic. So this is the lead in the bloodstream. You see, it's very toxic for people who know. Usually, this is a cutting point in the United States, but usually they don't treat or don't do anything until here. But let me tell you, 10 is bad. So these people have very high, and you can see the dramatic drop. So these are children with lead toxicity, acute lead toxicity symptoms over the age of 5. We had 3 more under age of 5 with the same benefits, but we didn't put them. And the levels in the blood came down dramatically. This is, for such a small group, a p-value of 0.016 is amazing. It's said that we didn't get 20 patients or 30 because we would have been in a major peer-reviewed journal, not in a low-impact peer-reviewed. But the criticism is, well, you move the kids from a toxic environment to a hospital, you have less lead exposure. When I'm kind of critiquing myself. But here is the interesting thing. In the same time, we saw a dramatic increase in the urinary excretion of lead. So we are trying to get, I'm willing to offer it. We're just trying to get somebody in the CDC, but now they've got their problem with the Ebola. It's interesting because this doctor asked me about the treatment, and I told her what to do 3 months ago, and now it was done in Germany successfully. I'll get to it at the end of the conversation, so you don't leave. But Anyway, you can see the dramatic increase in excretion in the urine. It's very exciting. You can see one compound we never expected does so many things because of this Dr. Ruth Cohen, who told me it's going to cure cancer, because of the galectin-3 and the wisdom of nature to protect the fruit from outside issues. So this is studies showing that pectins remove radioactive cesium. Okay, this is published papers. 204, 203. I told you, it left the literature and it made a comeback. So when the Fukushima happened, we were trying to tell, we couldn't find somebody that we can give it to because it's so hard to actually contribute something because of the politics and the, anyway, part of the world. And pectins bind and remove dioxin. That's very important. Bladder cancer, kidney cancer, prostate cancer. So that's the unique about this molecule. It removes toxins and it removes heavy metals. You can see the advantage compared to EDTA. Very different. Now, we didn't know it when we started in the 90s. The reports we were getting from people, especially when we did it with alginates, is their joint pains were getting better and their memory was getting better. And we didn't have the logic. Why? And only now, 10 years later, we are starting to figure out the mechanism. And, we got lucky a little bit with this, I admit, It's quite something. So, but the most exciting thing that is really getting the attention is fibrosis research. I really think that modified citrus pectin may turn into a household supplement, that we are very close to regular doctors prescribing it. Another 200, 300 years, So, as I said, galectin-3 plays a key role. Oops, again, I pushed the wrong one. So, it plays a key role in fibrosis through what I showed you before. It affects the scar tissue and the adverse remodeling. And that's how it affects every disease. So, for example, in cancer patients, you can see the galectin-3 going up as a reflection of the disease becoming metastatic. It's a marker. But what now has to be understood is the difference between injury repair and inflammation. It's a great subject to actually comprehend. And I published the first case report from a patient actually from this area that had an autoimmune disease and metastatic cancer. It's the first case report in a peer-reviewed journal that showed that this patient was prepared. I was preparing her for cancer treatment with chemotherapy by reducing the inflammation while the cancer was still growing. But the reduction of inflammation was so much more dramatic that the galectin-3 went down, which allowed her to have a dramatic response to the chemotherapy. So when the FDA approved this test for galectin-3, in the same time, once I ran out of candies, we are done. I got one more in my pocket. So we're almost done. One of my students, when I went to Israel, they brought me something which was healthy, and now I'm using the Ricola. It's not good it's good for the dentist, I guess, but not for me. So this is a very important study that was done in the UK by a very elegant study. They took mice and they made a kidney injury by injecting folic acid IV. Again, the same injury you get from radiation, the same injury. And what they saw that with the MCP, you did not get the fibrosis and the cell death. It protected the tissue. And we just now have shown in a very elegant study that we will present in American Academy of Cancer Research that it also enhances radiation itself as a therapy. But that's why I mentioned when you fly, you need to take MCP. Because one flight from here to Europe and back is almost like getting a CT scan. It's remarkable. Maybe a tip about flying. I met with the El Al pilots, Israeli airline pilots, 2 years ago, and most of them were very high officers in the Israeli Air Force, which is renowned, and most of them are PhDs, and they really take care of their health. It's one thing. And the second thing, their responsibility of flying a plane safely is like their mission. Like when they land like in Los Angeles, the whole thing is how am I going to be totally prepared to deliver the passengers safely back. But they know that when you cross latitude 45, your radiation doubles. And when you cross 60, your radiation triples. And they don't care what air control tells them or Israeli airline tells them. They bring the plane down to 33,000 feet at latitude 45, and they bring it to 30 or 31 at 65, because they don't want to get the radiation and they don't want the passengers to get it. And it's a very interesting issue. And by the way, they were telling me that with the 777, it even doesn't consume a lot of more gasoline. It can be solved by shielding the plane from cosmic radiation. Anybody who flies 100,000 miles or more is actually classified as a radiation worker, like somebody who works in a hospital. Double lymphoma, double melanoma. And there are ways to work with it. It's a lot of my research now. And I just finished the development of a system over many years. But MCP is one of the main compounds. I mean, the good thing is you can clear the radiation a few days afterward. And they know it. They are very, very knowledgeable. They know it takes 3 days to clear the radiation. But then if they stay too long, then the jet lag becomes an issue. So it was really fascinating to talk to them about it. It's one of the unspoken, hidden professional employment liability, because the airlines know it. If you talk to stewardesses, a lot of cancers, early menopause, but nobody is admitting it because it will be a hazard. But it is going to come up. So you could see all these people who are worried about it and no one is doing something about it. And then when I'm going to come from left field and do something, because I just finished the development of the system. And now we're going to test it in an inflammatory model to see that indeed we are reducing the radiation damage. The important thing is that, you can worry about something, but it's nice to worry about something when you have a solution, Otherwise you just worry. Nobody gets healthier from worrying, So this was a very important landmark study that got the whole idea of the fibrosis going. And that's a very important paper that was published in the American Heart Association journals, in one of the journals, showing that modified citrus pectin by inhibiting the galectin-3, it prevents vascular fibrosis better than any medication. And again, that's why now there's this interest. The EU is about to give, hopefully, a very big grant to study my preparation, because I can't afford these studies. They are millions of dollars. So, to summarize MCP in cancer treatment, MCP reduces the primary tumor, angiogenesis, metastatic, heavy metals, and MCP provides blocking of galectin-3, synergistic effect with chemotherapy, protection against post-radiation damage, detoxification, and immune support. And I don't think that and again, MCP has synergistic effect with cancer, with other chemotherapy drugs. These are the two papers from Iran. And actually one of them is from another center, ovarian and prostate. And MCP also is synergistic with different herbal formulas. I'm not showing you my other research with honokiol and with the breast formula, because I want to focus on this and show you something very exciting. So just to summarize MCP benefits: fights cancer growth and metastasis, reverses fibrosis. So what I hear from people, if you take enough and you have like inflammatory pain, you will feel the difference. Your inflammatory pain will go down, will get better. It's a rogue protein. I used to say it's a rag protein until my daughter told me, no, you say rogue. So you're going to be so proud of me. It's a rogue protein. It fights cardiovascular and kidney disease, safely chelates heavy metal, boosts immune function and efficacy, and synergizes with other therapies, including chemotherapy. And it's interesting. Even the big institute like MD Anderson, they've recognized that MCP is unique, and they have a great interest in researching it. So more and more research is going to come, but it's such a safe compound. And a comment I want to make is not all MCP is made alike. MCP is a generic name, and anybody can put a pectin in a bottle and call it MCP. It's a very specific structure. And most of the brands out now use my specific compound, but you never know. And again, before I go talk about other stuff, these are free books if any of you want to take. It's a nice read. It's the story of a cancer survivor that is centered around MCP, and I'm being interviewed like my story about it. Okay, so now I'm going to talk to a new field that I've started 3 years ago that really happened when I was with Dr. Ralph Moss in Germany in a clinic that uses plasma apheresis to remove TNF-alpha receptors and create an enhanced inflammatory response that can kill cancer and can kill the patient at the same time. First, he killed the patient for a few years. Now he kills more of the cancer because the inflammation is so strong. And then I wrote Ralph a note and I said, you know, I just made my biggest invention of my life. At least then, who knows what will happen. I'm not as old. So what is unique about therapeutic apheresis? Therapeutic apheresis is a procedure that is used, and I want to talk a little bit about emerging application and expanded clinical benefits. So it's a procedure that removes compounds from the plasma, including pro-inflammatory proteins, microbial agents, infections, hepatitis B, hepatitis A, HIV, Ebola virus. That's why this filter in Germany just cured an Ebola patient. I mean, it's a little bit pathetic. They bring these Ebola people from Africa, and what do? They give them fluids. That's really what they do. They give them fluids in a sterile environment. We just give them high-dose vitamin C IV, it will be different. And they don't give them any antiviral agent. But what such a thing will do, if you can take the load down, the body will recover. So now they published one case like this in Germany that had a response. It takes out lipids, especially oxidized lipids, and it takes heavy metals and toxins. So we actually do apheresis in our clinic. Apheresis in general is, that's actually just from this week. Apheresis, how is apheresis done? You remove the blood using the apheresis machine. Here is the blood coming in. It's separated between the cells and the plasma. The plasma comes in, it's being filtered, and then it puts together with the blood and it goes back to your body. So as a process, it's used for a lot of diseases. It's mainly, in the United States, it's not used a lot. It's used for autoimmune conditions, myasthenia gravis. It's used for elevated cholesterol where it's resistant to therapy, and it's either homozygous or heterozygous. If you go to your family doctor, you go to your cardiologist, I bet you that 68 to 80% of them didn't even hear about LDL apheresis, unless they are in Stanford or a big center. Only 1 out of 1,000,000 has homozygous hypercholesterolemia, very rare. But 200 out of 100,000. So in the Bay Area, there are about 16,000 people who need this treatment, and I think we are the only unit in the whole Bay Area, including the hospitals, because there's no awareness, and it's actually for this patient, it's paid by insurance. But there are other indicators that I'm interested in, hyperviscosity. These are things that it's used, Guillain-Barré. And again, differences, systemic lupus, sickle cell, blood incompatibility, multiple sclerosis. Now, apheresis in the United States is less common, as I mentioned. It's an expensive procedure. The filters for one procedure with all the wiring is close to $2,000, just the filters. So obviously, it's not something that if you don't have insurance, it's hard to do too many of them. And filters are removed, but one of the systems that is approved for LDL apheresis also removes this inflammatory compound, fibrinogen, CRP, LPA, and positively charged compounds such as heavy metals. So what do? I do different IVs and different treatments around it to let the body dump the toxins into the system. But why did I get into this? I got into this, again, first, inflammation drives, as we say, every chronic disease. Cancer, progression, cardiovascular, diabetes, kidney, autoimmune, neurological disease. That's example of some patients in our clinic. So the reason why I got to this, and I'll show you the next slide, I think, is because my discovery was that galectin-3 is actually a decoy molecule. If you think about it, when you get cancer, immediately the levels in the blood go up. And when they go up, or outside of the tumor, they cover the tumor. It becomes the survival mechanism for the chronic disease. So my concept was, let's remove galectin-3 via plasmapheresis. As a standalone, or with other inflammatory compounds, or doing it in a column one after the other, where I can individualize the apheresis using one of the approved regular dialysis machines, just changing the columns. There is more use in general of apheresis out of the United States, especially in Germany. There is hardly any in the United States. So this work, I'm really the only one who's doing it in the United States. For this common machine, the health machine, I'm the only one in the world who is doing this. But my goal is I'm just getting my hand wet as I'm becoming an expert in a new field. And it's very interesting. I'm getting so much support from the president of the International Apheresis Society, from the head of the Mayo Clinic apheresis, from the head of Harvard graft rejection, because they all know the other indications, their hands are tied, and here comes this guy and he's suddenly opening the field. So there's a lot of excitement. Now, so before I talk about the galectin-3, I want to show you some clinical benefits. Because usually these patients, when the insurance approves them, they come 10 minutes? Oh, really? Oh, perfect. I'll be done in 10 minutes. And so usually when a patient does it in the hospital, like when I went to the Mayo Clinic, you have the same patient coming for 10 or 15 years every 2 weeks. Well, we have a very big population of patients who are coming. So if we look at this data, so this machine is not the galectin-3 removal machine. It's just supposed to remove cholesterol. But I'm looking at the effect on galectin-3, and I haven't published this yet. And so you can see a small drop here. And then in the second treatment, you can see it bounced up more than the baseline, and then it dropped back.
It's really hard for you to masturbate.
Really? Can you see it actually or not really? Well, let me just show you one thing. This is a column of the galectin-3. This is a patient, let's say, a patient with very aggressive metastatic cancer, okay? The pre-treatment labs are 26 for galectin-3, very high. Remember the levels were like under 17.8? After treatment, it came down very dramatically. Treatment on the 14th. 16.5, not like I would do when I have my column, but 40%. Then it bounced back almost completely to 24.4 within a week, but this time it went down by more than 50%. Why did it go down more? Because all the lipids that were removed in the first time didn't come back again. Same concept of doing it before chemotherapy, before radiation. But here is the interesting thing, and I'm going to publish this one patient, is this system removes C-reactive protein very effectively. So it went down from 6.2 to 2.5, but it bounced up only 30%. Okay, and then it went down again by 50%. The reason that it did not bounce up so powerfully is because this patient has a lot of attempts to do injury repair, but they are not able to mount as good of an inflammatory response. You can see the immune system is not functioning well. Eventually, the inflammation will go higher. And that's the balance between injury repair and inflammation. And you have to see, because the treatments are different. The last thing that is fascinating is this is a marker called VEGF, vasoendothelial growth factor. There are a lot of drugs people are trying to develop. The normal is under 300. This is extremely high VEGF. That's aggressive cancer. And after the apheresis, look how dramatically it went down. So this is a patient with inflammatory cancer. The worst breast cancer is inflammatory breast cancer. So you can see the inflammation. Interesting, with other treatment now, this is staying at 300 weeks after the treatment because of other things that I'm doing, different IV that I didn't talk about, but also because we have used the apheresis to systemically cool down the system. So the thermography over the breast, over areas in the neck, turned from very inflamed to normal, which is what you need to happen in inflammatory cancer. So we're doing it a lot for infectious disease, but this is the first step before we actually develop this development. So right now in my journey, I am, this thing goes on YouTube, right? Okay, so I am one. So right now, I got patents in many countries, and I'm working with one of the, I would say maybe the most famous medical institute in this country, and we are doing already large animal studies to prove the concept. So this is a little bit about the concept of galectin-3. The idea is to use selective apheresis filter to remove galectin-3 from the plasma with or without other compounds. Change the course of numerous acute and chronic conditions, enhance the effectiveness of conventional treatments including oral drugs, chemotherapy and radiation, and improve immune function, and reduce short and long-term side effects and morbidity caused by invasive treatments. So prior research shown when you take mice that genetically don't have galectin-3, they're called galectin-3 knockout, they will not develop arthritis. When you inject galectin-3 into their peritoneum, they will show up with arthritis in the tissue. So the reverse concept has been proved. Now what we are doing in a nice way so we don't have to kill the animals or do anything, we're just creating a localized inflammation that is a model used for graft versus host, which we have shown will spike up the galectin-3 levels in the blood. And we developed the column already with an antibody that takes out selectively only galectin-3. And now we're about to start the study where we will remove the galectin-3. And we want to see, can we shorten the duration of the inflammation? If we can, it proves the concept for all of these diseases. So we are about 3 years into this research. We, it's mean Isaac and me. And and a few more researchers, but we are now at a stage, once we finish the proof of concept, then it's going to be very exciting, and it's going to be, we have to start the whole project. So we have a patent protection for this, and large enable proof of concept study to be conducted, and then galectin-3 specific column has been developed. So it's very exciting, and that's what really got me into the apheresis and why we started the apheresis in the clinic. And that's me in Tibet treating a monk a few years ago. So thank you very much. I finished on time.
We have time for questions. So
of
I'd
course.
like to take a few questions. Anyone have questions for?
Yes.
Operations you're doing now, are you also doing work with GF11 molecule where you can remove clean the plasma, and you isolate GF11 molecule and put it back into the human body and you
Could you
can
repeat the
regenerate?
question so the
Yeah, there was a question about using GF11 molecule. No, we don't. Right now what we are doing is we are doing the apheresis. Most of the patients are cancer patients, active cancer. And there's a large body of patients with severe Lyme's disease, the ones who are where the leading doctors are sending their leading patients. So what we do is we are more specifically cleaning the blood from toxins for hyperviscosity, and we are slowly studying things like the VEGF. Nobody knew about it. So we are taking one molecule at a time, and of course it's all out of my research curiosity. I'm funding it myself, so it's slowly.
How many treatments do you need?
It depends for what. For
Let's say Lyme's disease.
Can you repeat the question?
Yeah, how many treatments do we need? For Lyme's disease, it's tricky. Depends how severe is the Lyme. Some patients will feel a difference immediately. Some patients will take a number of treatments, and for Lyme's, it's valuable to do 2 treatments, one close to the other, because on the second one you can pull out other things. because the blood and you do, like for example, we had a patient with Lyme disease who came from Canada, and he clogged the filter after 2100 mLs of plasma, but he came again 4 weeks later, and again lipids come back after 2 weeks, but 4 weeks later we did 4000 ml and the filter wasn't clogged at all. So his blood was so much cleaner that there was less than half the material. But it's a work in progress. You know, I'm kind of, the only person I can consult with it is myself. So that's why every patient I sit and I change the treatment for every single patient. I know today we had a treatment, so I sit, I come in, and I do different things. For me, first of all, the process of taking the blood out, the blood, you know, which is controlled by the heart, it's incredible. You can really affect the inner of the person. But also, the person is different at the starting point and every point in the apheresis, because their blood constitution is changing. So it gives me an opportunity to see them differently during the process and treat them. So for example, I know I'm on video. For example, UBI, you know, UV radiation. So usually people who do UBI will take out 60 ml, 90 ml. Well, I go up to 1000 ml plasma. So I can do 4 liters of this, you know, so I can really affect, which is a known treatment, photopheresis is a known treatment for autoimmune conditions. And then when I do it, I can decide, am I continuing with vitamin C? When is the glutathione coming in? And also, do I want to give them agent like artesunate that have, you know, extracellular anti-parasitic effect and will work synergistically with the UBI? So it's that's what I mean. It's like this with, nobody's looking at this like this. Everybody, so it's really like creating a whole new medicine. So that's how I feel, that's how other people feel. Yes?
Do you think it would have some effect at all if you took MCP and gave blood?
If you took MCP and did what?
Gave blood.
Blood donation.
Donated. Doing both.
Oh, no. Oh, you mean blood donation from a point of view of a therapeutic effect for the person? You know, it would be like this if you did a chelation agent that went into the tissue, but then it's not very ethical. You're giving somebody else a lot of heavy metals. You know, there's a very interesting concept. We all have this idea about like positive thinking, so we see light coming in and disease going out. But who is taking the disease that we are giving out, right? Do you ever think about it? So the most powerful healing is called Tonglin, where you take other people's suffering and you give them light. And now in Israel, there was a very well-known healer who came to my retreat, and she couldn't heal her mother. That's how she started. She was one of these amateur psychics. But then when she took Tonglin, when she took her mother's suffering in her and gave her love, not just sent her the light, then suddenly she called her mother and said, you know, wow, for the first time I really feel better. So that's a different approach. And you can talk a lot about it, but MCP in general mainly chelates in the blood. So giving blood for people with hyperviscosity is not a bad idea. Definitely. Yes?
The best source of MCP?
The best source for MCP is Pectasol C. That's the one that all the studies have been done on. Pectasol, P-E-C-T-A, Sol C. And it's from Econugenics, terrible name, ECONUGENICS, econugenics.com. And again, it's Pectasol C. So all the trials I've shown you, all the clinical trials I've shown you were all done on this.
Did you have a study on MCP, and autistic children?
Yes. Did I study MCP and autistic children? We had a lot of feedback from a combination that we created of alginates with MCP. And actually one of them, we even put some kelp. And I formulated it for another company who sold the product. And I got approached by some mother that had a lot of benefit. But this company wanted to go into a country in Asia. So we had to take out the alginate and put chlorella instead. And they got dozens of letters from the mothers that the effect is gone. So that was interesting. That's like a live clinical trial you never expected. So the combination of MCP alginate is very useful, but you have to start very low. And again, the idea is that you chelate from the system, from the blood and from the gut, and slowly the tissues will. So definitely there are a lot. There is a second product. It's a detox formula that I'm upgrading now that I did specifically for autistic children. This is actually a formula that sometimes it happens to me that I got the whole formula in a dream. And then that doesn't mean I'm going to use it. I wake up, I write it, and then my researchers have to start validating every ingredient. But it was specifically, once the system is working, once the bloodstream and the gut is working, then you can start chelating from the tissues. Otherwise, you can really aggravate these children. Yes?
To continue what I was asking you earlier, if a person's taking oral EDTA as a preventative, and they want to switch to Pectisol, I noticed you've got your alginate only in capsules. And I was told today the reason why is it's hard to mix.
Right.
And yet I hear you saying you want to do 15 grams. Your non-alginate formula are 5-gram scoops, which is a lot easier. What's better, to do the larger amount without the alginate or the smaller amount with the alginate?
You got some good questions. In general, if your problem is specifically heavy metals, it's useful to do the alginate MCP. But because the alginate prevents the reabsorption in the gut, you need a lower dose. But what's happening now, like I do only the MCP. And the reason is the galectin-3 research. It's so powerful, the galectin-3 blocking. It's really a longevity compound. But if you have an issue, and over time it will clean because you're taking higher doses. But if you have a specific issue with heavy metals, then take the MCP, take maybe 10 grams, and take a few capsules of the alginate with MCP. Yeah. And then I often do it this way.
You had mentioned that you can still do the oral EDTA.
Definitely.
But if you don't want to do that, will this replace the oral?
It will. The main problem is with lead. MCP is the best chelator of lead. It's incredible how the tight bond. The problem is that a lot of the lead is very tightly bound in the bones. It becomes a part of the matrix of the bones. And it takes years and years, if at all, to release it from the bones. And in this sense, even EDTA will not do it. And in this sense, if you know you have a lot of lead, I would still consider doing a little bit of EDTA. But EDTA is much more effective when it does intravenously. And some people talk about calcium. Gary Gordon talks about calcium EDTA. Calcium EDTA does not benefit the circulation. Does not, no matter what Gary Gordon says. It does not. And also it does not take out mercury. Just doesn't, it's not true.
EDTA does not?
The calcium EDTA. EDTA is a great affinity for lead. The sodium EDTA that you have to take out very slowly, because it can affect the kidneys, has an effect on the circulation. So if you are considering circulatory issues, then sodium EDTA IV is a better choice. But your best bet if you have circulatory issues and heavy metal is just to take high dose of modified citrus pectin. Because slowly it will make the difference. Because of the galectin-3.
Let's go ahead and
thank you.